In this next video, I want to talk a little bit about medical ethics. So ethics are a huge part of medicine. It kind of dictates why doctors make the decisions they do in different ethical situations. Um, Ethics are sometimes a hotly contested aspect of medicine. It's for things like abortion and stuff like that. The purpose of the video isn't to provide my opinion, but it's to kind of give what's commonly accepted in the medical community. So one common ethics concept is beneficence, which means you are to always do what's in the best interest of the patient, unless the patient does not want that treatment, in which the patient's autonomy must always be respected. The other thing is non-malfeasance, which means that you do no harm to the patient. If there's a treatment or if there's a medicine that you know is going to do harm, it is unethical to give that to the patient. I want to talk a little bit more about beneficence, which is acting in the best interest of the patient. I mentioned briefly that patient autonomy supersedes that. So, for example, if a patient say a patient has cancer and there's a treatment for that cancer, you have to give all the information, including the risks of that treatment, what the treatment does, what will happen if you don't give that treatment, and that's the consent process. You must give that before any treatment, whether it's surgery, medicine, anything like that. That must be given. Once that information is given, if the patient declines, the physician has to abide by the patient's request as long as they have decision making capacity. Decision making capacity has 4 different components. They are able to communicate a decision. They're able to understand the consequences of their decisions, and they are able to understand what that decision means. So those are the biggest things of a patient decision making capacity. So the next thing I want to talk about is end of life care. So hospice care is only given if the patient has less than 6 months to live, and if the patient decides to withdraw life sustaining treatment. Now, the primary purpose of hospice care is palliative care and comfort care. So you're not trying to treat whatever disease they have. You're trying to the primary purpose of hospice care is comfort. So that could be pain, painkillers. That could be living at home, getting in-person care, avoiding any unnecessary surgeries and things like that. It's purely palliative. It's purely to relieve comfort, not necessarily treat the underlying disease. I want to next talk about surrogate decision making. So suppose that someone is unable to make their own decision, where they might be in a coma, they might just not have decision making capacity. Those things might be the case, and in that case, the next decision maker is the spouse. And if the spouse is unable to make that decision, then it's the eldest living child, then it's the sibling, and then it's the parents, and then it's friends. So that's the order it goes in for surrogate decision making. I also want to talk about advance directives. So an advance directive is a document expressing the how a patient wants to be treated in case they're incapacitated. So, for example, a patient might have an advance directive that says "do not resuscitate," which means don't perform cardiopulmonary resuscitation if they go into cardiac arrest. So, or if they go into asystole of any kind. So the advance directive supersedes any surrogate decision making, because that was their decision when they were capacitated. However, if a person is still capacitated and if a person is able to make their own decision, they say, never mind, I want CPR to be done in case I need it, then their most recent decision is what holds true.